Welcome, brothers and sisters, to your wellspring of knowledge.
Hello friends, I am by the names of Joseph Ndaishimi. Today's topic is part 2 of all about smoking, which is smoking and surgery or smoking and surgical anesthesia. Friends, as you have seen, in the previous presentation, please, it's not a secret that smoking causes serious health problems like heart disease, COPD, chronic obstructive disease, or even lung cancer. You have to know that once you are a smoker, you are much more dependent to ventilator, the machine that breathes for you after surgery. Therefore, if you are having surgery, you have to stop smoking to alleviate the smoking complication that can occur during and after surgical procedure. There are many reasons for you to stop smoking before surgery. First one, there is reduction in nicotine and carbon monoxide in the blood. Friends, once you stop smoking, even for one day, it reduces the plasma concentration levels of nicotine and carbon monoxide in the blood, which in turn improves the oxygen carriage and then better oxygenation to tissue. Second, quitting smoking improves blood flow, which also recovers healing process. Friends, quitting smoking even one day before surgery can lower your risk of complication by improving blood flow, and then healing process is somehow restored. So your surgical wound is not more likely to get infected. Third, because smoking, remember, is the major cause of heart disease, stopping it reduces the incidence of heart attack during and after surgery. These are the main reasons for you to stop smoking before surgery. Friends, here are 7 ways for you to quit smoking. It's not easy. It's not easy for smokers to quit smoking, but these are 7 ways that can help you to stop smoking. Sure, if you read this and take it as yours, please, it will help you. It will help you for sure. First one, friend, be angle of smoking. Be angle of smoking. For example, first think again on the catastrophic effects of smoking on in your daily life. For example, poor outcome or loss of life once you meet surgery. That's one. Second, set a quit date. For example, you can pick the date in the next few weeks and you share it to your relatives, friends, family, and mark it on your calendar. Third, avoid smoking triggers. For instance, don't be a companion of smoking people, but look for other friends who are not smokers. Fourth, don't be alone for a long time. Fifth, don't think much on the time elapsed without smoking. Sixth, schedule times of relaxation and physical exercise. The last, ask for doctors to prescribe nicotine replacement for you. There's the anesthetic implication of the smoking effects. As you have seen the previous presentation, the smoking person have many physiological changes, especially respiratory, cardiovascular, even in gastrointestinal tract. First one on respiration, we have decreased oxygen carriage, which can expose the patients to hypoxemia during and after surgery. Second, remember these patients has irritable upper airways, which can expose him to laryngospasm once you give it a light anesthesia. Third, on respiratory system, remember that the ciliary function of this respiratory system of the patient, this patient is severely depressed. The clearance is, is severely impaired, which leads to latent secretions and even infections. On the cardiovascular, because of nicotine, you know, it activates the adrenomedulla to release much plasma catecholamines. Those person most time have hypertension, which can expose him to perioperative ischemia. They have ischemic heart disease, which can uh, lead to myocardial infarction and anesthesia. And they have more coagulable blood, which can expose him to thrombosis. Worst outcome after coronary artery bypass, graft surgery, and vascular surgery. On the gastrointestinal tract, they usually have Crohn's disease, gastroesophageal disease, and peptic ulcer. All that can expose the patient to malnutrition because of poor absorption or aspiration pneumonia, or once uh, he regurgitates acidic contents into trachea. Now, this is the management of anesthesia in smokers. How can you manage surgery of these patients? It's not easy, but possible. So stay with me. I give you the hints that can help you to safely anesthetize these patients. First one, please advise your patient to stop smoking. On that point, ideally stop smoking for at least 2 months if possible, prior to surgery. Second, you have to know that stopping smoking for 24 hours before surgery can neutralize some effects of nicotine and carboxyhemoglobin. If the operation is scheduled for the next morning, please stop smoking in the previous evening. Prepare your patient by treating the infections such as chronic bronchitis. Prescribe bronchodilators, beta agonist, for example, salbutamol, breathing exercise, chest physiotherapy in symptomatic patients. Please do blood gases to get baseline arterial partial pressure of oxygen and the arterial partial pressure of carbon dioxide if the operation is too long. Friends, pay attention for those people with smoking status. Because of impaired respiratory system, cardiovascular, what's better for you is to use local regional anesthetics technique instead of using general anesthesia, because it is so difficult for them to manipulate their respiration. Premedication use sympatholytic agent like glucopyrrolate, atropine, once their heart rate are not too high to delay circulations, but better use glucopyrrolate because it doesn't increase much the heart rate of the patient. Second, use anxiolytic agents such as midazolam to negate psychological effects of stopping smoking before surgery. But you have to pay attention because midazolam, of course, benzodiazepine, they are respiratory depressant. What's better, use smaller dose or judge according to the patient. Third, please, it's not necessary to premedicate the patient for postoperative nausea and vomiting because there is such evidence that they are not prone to vomiting compared to non-smokers. General anesthesia of this patient. During induction, do pre-oxygenation to decrease carbon monoxide and to increase FRC with oxygen. When using IV induction agents, any intravenous induction is satisfactory, but don't use ketamine alone because it's more airway secretive. Use intravenous lidocaine to prevent laryngospasm during intubation. When using induction with volatile agents, for example, sevoflurane or halothane is preferred, especially in pediatric patients. Avoid manipulating under light anesthesia, which may result in coughing, breath holding, laryngospasm, or bronchospasm. During intubation, friends, you have to have intubation spray with lidocaine before to anesthetize the larynx and suppress laryngeal hyperreactivity. In maintenance, please avoid light anesthesia because it can lead to bronchospasm. Second, avoid desiflurane or isoflurane because they are all respiratory irritants. They stimulate respiratory irritant receptors in chronic smokers and thereby sympathadrenal system, resulting in higher blood pressure and tachycardia. Increase minute volume to maintain same arterial pressure of carbon dioxide. In monitoring, please pay attention for pulse oximeter because it can overestimate the value of oxygenated hemoglobin. Because as you know, hemoglobin doesn't show us what's really the amount of oxygen that's delivered to tissue, but it shows us the number of or the amount of oxygen that hemoglobin, the amount of oxygen, but not only oxygen, all other gases such as carbon monoxide, uh, uh, and the other gases in the blood. It shows us the amount of. It shows us how much the hemoglobin is saturated, either with oxygen or other things. Please pay attention for this patient. Don't rely on the pulse oximeter or oximeter. Use EKG monitor, especially in those having coronary heart disease, since ventricular arrhythmia may occur during anesthesia. In the long operation, carry out intermittent blood gas analysis to check the arterial partial pressure of carbon dioxide, since the arterial partial pressure of carbon dioxide on the, and the tidal capnograph is higher than in non-smoking patients. Now, how can you recover? How can you emerge those patients from anesthesia? Please don't extubate those patients under light anesthesia, because once they cough, bless the hold, they are at risk of developing laryngospasm or bronchospasm, as you have seen. In postoperative period, give oxygen in the recovery room while being transported in for some time in the ward. Postoperatively, administer more analgesia which are needed due to anxiety from stopping smoking, decrease the pain threshold, and increase the metabolism of the drug, because chronic smoking it induces hepatic cytochrome 450. But pay attention on the opioids. What's better? Choose those opioids that are less respiratory depressants. Last, you have to give breathing exercise and chest physiotherapy to symptomatic uh, smokers to dry and evacuate those airway secretions and spasm. Friends, thank you for being with me throughout this presentation. This is the take-home message. Please, quitting smoking for at least 1 day will lower your carboxyhemoglobin and nicotine level in the blood. Second, you have to know that quitting smoking for as little as the 2 to 3 weeks improves wound healing process. Quitting smoking between 6 to 8 weeks improves ciliary movement and respiratory function. And then it's a great job of both anesthesia provider and the surgeon to optimize the patient before operation for better surgical outcome of the patient. Friends, thank you for taking your time watching this video. I really know that you have extracted some useful things that can help you to be well equipped in your daily life. And even in the case of surgery, you have known that you have to stop smoking for